Warm welcome. It's a pleasure seeing so many people, so many friends and colleagues here. Welcome to our symposium organized by the Oregon Center for Lung Cancer. It's a pleasure inviting you, our colleagues, our industry representatives, and in particular our international colleagues and guests which will be talking to us today. Many thanks for being with us. Today it is the idea to present the current activities in clinical science, in clinical research, but also in translational research in the field of lung cancer at the University Hospital Zurich, and it's a pleasure to invite you and welcome you here. My name is Matthias Guckenberger. I'm representing the Comprehensive Cancer Center, and I would like to give you a quick outlook of what is happening. Today we're going to focus on lung cancer. We have organized our educational activities around our organ and disease group. So you can see today it's about lung cancer, but there are many other interesting symposia about prostate cancer, highlights in radiation oncology, oncology and hematology, colorectal, and so on and so forth. So if you're interested in the latest updates, please take a picture. I've already seen some of you taking it, and be with us in the next couple of months. Also very important to inform you again about our key conferences in 2026. You know, we are having on a regular basis 4 conferences, which is on central nervous system brain metastasis, and the others you can see listed here. And with that, I would like to thank, of course, our supporters and our pharma representatives, platinum, gold, silver, and bronze sponsors. Without your support, symposia like this wouldn't be possible. And with that, I would like to hand over to Isabelle Schmitt-Opitz, the chair of our Lung Cancer Organ Center, to introduce you to the program and open our symposium today. Isabelle, the floor is yours.
Thank you, Matthias, for this nice overview of our Comprehensive Cancer Center activity. So my name is Isabelle Schmitt-Opitz. I'm the chair of the Lung Cancer Center, also the director of the Department of Thoracic Surgery. And together with my colleagues from the Lung Cancer Center, I think we designed a very nice program for you to give you quite a comprehensive overview what's currently happening in small cell and non-small cell lung cancer. And so with this, I want to immediately start and like to introduce our first speaker, which is Dr. Antonio Calles from Hospital General Universitario Gregorio Marañón in Madrid, Spain. And he will start by giving us an overview about small cell lung cancer, what are the current and future treatment landscape. Thank you, Antonio, for coming to Zurich.
Thank you very much, Isabelle, for the kind introduction. Hope you get well very soon. It's my privilege to be here. Thank you for the invitation. And I will update on the treatment of small cell lung cancer. It's been a very, very intense year, 2025, that we won't forget. These are my potential conflicts of interest for today's introduction. And this is how small cell lung cancer is treated in 2025. We know that the combination of chemo plus immunotherapy in newly diagnosed small cell lung cancer with extensive stage improves survival. But since 2025, we know from the INFORTE trial that adding lurbinectedin in the maintenance setting after induction chemo-IO improves survival by a mean of 16.4 months. And after that, upon progression, tarlatamab improves overall survival over topotecan with a median OS of 13.6 months. In later stages, we can use conventional chemotherapy, but currently we are thinking about patients that are living more than 2 to 3 years. That was completely unthinkable a couple of years ago. I will briefly summarize the treatment of limited stage small cell lung cancer. I won't go through the role of surgery for these patients, but especially for the current evidence of 2 critical treatments, systemic therapies and radiation therapy. We know that durvalumab consolidation, 2 years of treatment after definitive chemoradiation, is now the standard of care. It improved median overall survival with a median OS of more than 3 years, with nearly half of the patients without disease progression upon 2 years of treatment, and this represents a new landmark for the treatment of limited stage small cell lung cancer. There has been also the idea of incorporating immunotherapy earlier in the treatment of these patients, incorporating immunotherapy with concurrent chemoradiation, but as happened with non-small cell lung cancer, this strategy didn't improve neither PFS or overall survival. Reasons are unclear, but perhaps it's not a good idea to radiate the lymph nodes in the primary tumor while giving immunotherapy. But it's very consistent, this kind of negative trials in the locally advanced disease. Probably the most important advances has come from the radiation therapy, high dose, hyperfractionating radiotherapy in 3 weeks, escalating until 60 degrees, is safe, is feasible, and improves survival. This is the Chinese data that was previously communicated last year and the recently published Scandinavian randomized phase 2 trial with a median overall survival that can be up to 60 months in the Chinese population and 45 months in the Caucasian population. Remember that these are trials before the immunotherapy era, so we can perhaps achieve the same results that consolidation durvalumab with high-dose hyperfractionating radiotherapy. So think about the combination of high-dose hyperfractioning plus consolidation durvalumab. We don't have this data, but we are currently implementing this treatment strategy in our patients. Regarding the management of extensive stage small cell lung cancer, we stick to the ESMO guidelines, so patients with good performance status are considered for treatment with the combination of chemo-IO. For patients with poor performance status due to the disease, we try to give at least the first lines of chemo and then add immunotherapy on top of chemotherapy. I think that from the different randomized phase 3 trial, the benefit of adding immunotherapy is quite consistent in terms of PFS and overall survival, very similar across trials with different anti-PD-1, PD-1, and also the different parts of the world, with a roughly 15% of long-term survivals at 4 years. So, well, it's better than what we had many years ago. That was less than 5%. Now we are roughly in the 15%. We don't have any predictive marker of long-term benefit for these patients, so you need to treat all your patients up front to get to these results. There's been recently attempts to improve the overall survival of these patients. Unfortunately, all the trials have become negative. These are the 2 anti-TIGIT phase 3 trial. The first one, tiragolumab plus ACE. The second one, the conformulation of vibostolimab plus pembro. Both trials were complete negative, actually, with some trend to worse outcomes in the TIGIT arm, probably due to a higher number of infections and side effects of the experimental arm. To my knowledge, this is probably the most promising agents, coming of B-specific PD-1 plus VEGF inhibitors. We have early data or ivonescimab plus chemotherapy and pumitamig plus chemotherapy in this setting with very strong and robust responses. However, we don't know the contribution of the agents in these trials. And these 2 agents and others are moving in the first-line setting in a randomized phase 3 clinical trials. But today, probably one of the most important trials that we have had in the 2025 is the IM40 trial. This is a maintenance treatment, so the patients complete 4 cycles of chemo plus atezolizumab, and then patients who had not progressed to this induction therapy were randomized to continue to atezolizumab, that is the control arm, or to combine lurbinectedin plus atezolizumab. Lurbinectedin was used at full dose of 3.2 milligrams per kg every 3 weeks until progression, and the trial met its dual endpoints of progression-free survival with a hazard ratio of 0.52 compared to only atezolizumab as maintenance, but also in overall survival with a survival gain of more than 3 months with a hazard ratio of 0.35. So This is the first time that a systemic therapy improves overall survival beyond first-line therapy, and is now this regimen FDA approved for this indication. The side effects of the combination are as expected for the lurbinectedin safety profile. So most of the toxicity is transient hematological toxicity, especially neutropenia and thrombocytopenia, also nausea, fatigue, and grade 1, grade 2 transient transaminase elevation that can be controlled with relatively easy with those controls. And more recently, a few weeks ago, it was presented in the ESMO meeting, an update of the INFORTE trial, analyzing the site of progression. So patients who received lurbinectedin plus atezolizumab had less liver metastasis at only site of progression, and fewer new onset of progressions at other sites, including the brain. Because the patients were on treatment with lurbinectedin longer than in the control arm, the site of progression in the brain was numerically higher. This only annotated the first time the patient progressed, so we don't have further follow-up of these patients, and it has to be symptomatic because it was not specifically addressed the site of progression into the brain with regular brain MRIs. Regarding the efficacy of the treatment, upon the response to the previous induction chemo-IO, the benefit was consistent regardless of the response. It could be stable disease, partial response, or complete response. The patient benefit from the maintenance lurbinectedin plus atezolizumab, both in PFS terms and overall survival terms, and provides further significance of the use of this combination in the maintenance setting. Moving forward, in the second-line setting, this is a situation that nearly only 50% of the patients are able to receive a systemic therapy. So we know that there are differences by the American and the European guidelines, basically based on the timeline that is used to consider the disease chemosensitive or chemo-resistant. We prefer the terms of 3 months, 90 days from the last dose of chemotherapy, rather than 6 months that is used in the NCCN guidelines. In the NCCN guidelines, you can see that many agents are recommended, including lurbinectedin, tarlatamab, different chemo regimens, including single agent immunotherapy. This is not the way in the European Union. We have more restriction in the treatments that we can use. We don't use single agent immunotherapy because it's basically inferior to standard chemotherapy. Lurbinectedin can be used both in platinum sensitive and platinum resistant disease. But I think that there are many agents that are emerging, and now we need to focus on the most promising ones. I will focus in this part of the presentation in the T-cell engagers. That is HLA no restricted recognition of the cancer cell based on expression of a common marker, in this case the DLL3, that makes a direct activation of the T-cell in the tumor microenvironment. There are other B-specific and Treg-specific T-cell engagers under the clinical evaluation. Also, again, new alkylating agents like lurbinectedin. And there is a plethora of new antibody-drug conjugates that use different markers in the cancer cell that can be used as a Trojan horse to introduce chemotherapy into the cancer cells. So we will focus first in the T-cell engagers. These were the data that was presented and published simultaneously during ASCO this year of tarlatamab. It was a randomized 1-to-1 tarlatamab versus treatment of choice chemotherapy. It could be topotecan, lurbinectedin, or amrubicin in Japan. The trial met its primary endpoint of overall survival with a median overall survival of 13.6 months for tarlatamab compared to the classical 8 months overall survival in this setting for the control arm. The hazard ratio was 0.6, so a clear positive trial. There's not such a difference in progression-free survival. You can see that 80% of the patients will progress within the first year of treatment. So most of the patients will progress to the treatment, but there is a 20% of the patients that will derive a strong benefit of this therapy. Also, these responses, the patients who respond were longer than those who respond to chemotherapy. So there is a carry-on effect that we have seen previously in other immunotherapy. So you need to treat all the patients to see what patient is going to be under response for more than a year. So there is no good biomarkers for tarlatamab in this setting nowadays. Recently, in ESMO, it's been updated the survival benefit regarding previous anti-PD-1, PD-L1 therapy in the first line, or the platinum-free interval. You can see here that regardless of the previous treatment and the platinum sensitivity or resistance, the benefit was seen with tarlatamab in all these situations. And regarding toxicity, it's important to highlight that tarlatamab is less toxic overall than regular chemotherapy. However, it has a different toxicity profile and a different way of administration that has to be considered. Most of the toxicities with tarlatamab appeared during the first 2 cycles. CRS and ICANS was particularly higher in the first cycle and the second cycle. At the beginning of the trial, was administered in patient for 48 hours. Upon amendment, it was allowed to be administered in an ambulatory basis with only 8 hours in the outpatient. And the quality of life also was improved with the tarlatamab versus chemotherapy. So this is nowadays a standard of care when available. The incidence and severity of CRS and the dynamics of ICANS has been explained with more granularity during the ESMO meeting. So no matter if the patient had previously brain metastasis, liver metastasis, tumor burden, or performance status, the degree of the CRS was similar. So there is no clinical factors that makes you to understand which patient is going to develop CRS during the first 1 or 2 cycles. And I think it's important to highlight a new onset of neurotoxicity. One of them, it could be dysgeusia. It is highly reported, or probably underreported, because it's not well covered in the PROs or during the questionnaire. But we see also in the clinic, dysgeusia is very prominent in these patients, and this can be a new onset of ICANS. It could be a neurological disorder that we consider as a new ICANS to be followed up. Tarlatamab is being extensively studied in small cell lung cancer, including consolidation after definitive chemoradiation in limited stage small cell lung cancer, but also in the maintenance setting after induction chemotherapy, very similar to the INFORTE trial, and also in combination with chemo-IO since the diagnosis of extensive stage small cell lung cancer. This is the data that has been recently presented of the phase 1 Delphi 303 trial of the combination of tarlatamab plus chemo-IO. It could be either atezolizumab or durvalumab. There are different cohorts exploring not only the combination of chemo plus IO, but also the maintenance setting with durva and atezolizumab. You can see here that overall it was feasible to administer the treatment. Most of the toxicity happened during the first cycle, so it's very challenging, the first cycle, chemo, IO plus tarlatamab. CRS and ICANS also occurred in the first cycle as well, so no CRS observed upon cycle 2 in this trial. And I think that the most important figure here is the median PFS. There are some difference between durva and atezo in terms of the performance. I think it could be also an artifact of the observation, because it was not planned to detect such a differences. But overall, you see that the median overall survival and the median PFS is very high. So median OS is 80% at the first years, meaning that patients will be on treatment for a long period of time, and this could be potentially a new standard of care in the future when the phase 3 trial is complete. The question here and the point of most debate was whether or not we need to include tarlatamab in cycle 1 or cycle 2, or we can wait to the completion of the 4 cycles of chemo-IO and then include tarlatamab in the maintenance setting. The numbers are pretty similar regardless of induction or maintenance, so we will need to see a further phase 3 trial to determine what is the best strategy to incorporate T-cell engagers in this population. Of course, this is not the only in class. There are at least others. This I want to highlight obristamic from Beringen Ingelheim and gogatamig from Harpoon Therapeutics that was previously acquired by Merck. Recent updates of this last agent shows us a 50% response rate in patients with small cell lung cancer, but also with other neuroendocrine tumors as well, with a rate of CRS of 55%, mostly grade 1 and grade 2. So we will see the development of these T-cell engagers in this setting. Specifically, the Darion-8 trial was presented as well, very similar in design to the Delphi phase 1 trial. You can see here again a PFS rate very high when the T-cell engager was combined with chemo-IO in the first-line setting. Most of the toxicity happened in the first cycle as well. So the next step, the natural step, is to be incorporated in the first-line chemo-IO for these patients. Moving forward, lurbinectedin is FDA approved, and it can be accessed to the orphan drug designation of this drug of patients who progressed to previously chemotherapy with a response rate of 35%. The confirmatory phase 3 trial, the Atlantis trial, was negative, but of remark, lurbinectedin wasn't used here at full dose and was combined with doxorubicin. There is an ongoing phase 3 trial, that is the Lagoon trial, ongoing in the same setting. We are waiting for the readout of the results. Of remark, the toxicity profile was better than topotecan or CAF, so this is something to be considered in patients in second line, because they usually have many comorbidities and side effects for the treatment, and it can be ameliorated with better tolerated drugs. There is a lot of rationale of combining lurbinectedin with immune checkpoint inhibitors. It has been demonstrated both preclinically and clinically. There are two phase 1-2 trials, the Looper and the 2 small trial, that were the foundation of the INFORTE trial, showing that the combination of Lurbi plus immune checkpoint inhibitors may improve the effects of each agent alone. And now we are waiting for the Lagoon trial, that is the confirmatory phase 3 trial in the third line setting. The last part of the talks is about ADCs. There are many tumor markers expressed in the surface of the small cell and cancer cells. I will highlight here TROP2, DLL3, and SIT6 as the most important ones. Here you have some sort of summary of the different agents. There are more than 5 agents per target. You can see here B7H3, TROP2, SIT6, and DLL3 with different grades of activity. To me, the most important thing is that to become very active in small cell lung cancer, the payload has to be a topoisomerase 1 inhibitor, direct or indirect. Others doesn't work very well in small cell lung cancer. And the target, we don't know exactly the biology, the exact biology of this target, so we can expect somehow very early resistant mechanisms if these targets are not biologically important for small cell lung cancer survival. I will show you here the most mature data of ifinatamab deruxtecan, IDXD, in the IDA Lancer 1 study, with a response rate of nearly 50% of the patient and a median PFS of 4.9 months. Most of the toxicity is related to the payload, so alopecia, gastrointestinal disorders, and hematological disorders, and around 13%, 15% of ILD, of interstitial lung disease. This drug is being evaluated both in the second line compared to the standard of care chemotherapy, and also incorporated in the first line with chemo plus IO. Saci-govitecan, there is another TROP2 in the game. This previously demonstrated an overall response rate of 42% in previously treated small cell lung cancer, and the trial, phase 3 trial, confirmatory trial, is ongoing. And the last ADC I want to highlight is targeting 6/6. You can see here that AbbVie has two different assets, one with a calicamine payload and the other one anti-top1 payload. The antibody, the epitope that they recognize exactly the same. You can see the difference in terms of response rate, only 25% with the calicamine payload and up to 60% with anti-top1 payload. So it's very important, the payload. Now this drug is moving in the first line setting. So in conclusion, I think that thoracic radiotherapy in combination with chemotherapy and consolidation durvalumab and considering high dose hyperfraction is the standard of care of limited stage small cell lung cancer, anti-PD-L1 therapy in combination with chemotherapy followed by lurbinectedin plus atezolizumab is the standard of care of newly diagnosed small cell lung cancer, and at the relapse, tarlatamab will be the standard of care, but other ADCs and other drugs are coming. And the most important challenge in small cell lung cancer is to identify subset of patients to give these very expensive and very difficult treatments to the right patient. And with that, I want to be optimistic in the future and to see how we will incorporate these agents in a different sequence to improve the survival in more than 3 years, probably. That is what we are seeing in our clinical practice. Patients with metastatic small cell lung cancer living for 4 and 5 years. That was clearly unexpected many years before. Thank you very much.
Thank you. Thank you for this excellent overview. We might have one burning question time for, but really only one short. Because if not, I would like to move forward. Thank you, Antonio. To our next speaker, keynote speaker, it's Professor Lizza Hendrikks. She's Associate Professor in Maastricht University Medical Center. And it's my pleasure to welcome here Lizza. She's also the co-chair of ERTC Lung Group, was heavily involved in this year's ESMO program, which was excellent. Congratulations again. And she will speak about resectable non-small cell lung cancer multimodal care. Thank you for coming, Lizza.
Yes, okay. Well, my disclosures again then. And I think before I start, I want to give some historical data and current standard of treatment for resectable non-small cell. And I think some very important questions. Did we have an adequate workup? Is it resectable? Should we give neoadjuvant, adjuvant, or perioperative systemic therapy? Is it resection or radiotherapy a resectable stage 3? And can we even make borderline or unresectable non-small cell resectable? And to end with targeted therapy. If you look at the landscape of approved treatments for resectable non-small cell, then it's based on stage, PD-L1 level, the presence of EGFR and ALK, but also the EMA, FDA, and national approval status. You give neoadjuvant chemo IO, you give adjuvant IO, or you give a perioperative regimen, or for those with EGFR and ALK, you give adjuvant TKI. And historically, if you look at suboptimally staged patients, there was no benefit for 2 local therapies versus 1, and neoadjuvant chemotherapy provided similar long-term outcomes as adjuvant chemotherapy. I know my talk was on resectable, but I think we also need to look a little bit at unresectable, because there was no clear definition of unresectable in any of these trials. And maybe with the treatments we have now, we need to change our view on these patients. But again, PD-L1, presence of EGFR, EMA, FDA, national approval status. You have for those without EGFR chemoradiotherapy, adjuvant durvalumab, or chemoradiotherapy and adjuvant osimertinib for EGFR mutated patients. And again, I put the history below it. Sequential chemoradiotherapy is better than radiotherapy. Concurrent is better than sequential. Type of chemo, induction, consolidation, all doesn't matter. And higher radiotherapy dose also no benefit. So here I think in the end, the latest benefit came from adjuvant immunotherapy and targeted therapy. And before we start to treat these patients, we really need to stage these patients and have a functional assessment. This is an EOTC consensus definition, but I think this is applicable in daily clinical practice, and I hope it will be published soon. You need to have a contrast-enhanced chest CT, you need to have a PET scan, brain imaging, you need to have invasive mediastinal nodal staging, especially for stage 3, and additional tests depending on the location of the tumor. And I think we should not decide for ourselves what the best treatment for a patient is with resectable non-small cell. You need a good thoracic surgeon, radiation oncologist, medical oncologist, pulmonologist, imaging specialist, and pathologist, and in the end, the MDT needs to decide. So how can we decide which tumor is resectable? Again, here to see consensus definition, and this was on stage 3 because I think we have the huge debate in stage 3. And it's mainly, I think, for the T4 invasion and the N2 multi where we have the discussion. Very invasive N2 and 3, I think within a clinical trial of very experienced surgeons maybe is resectable, but I think in general we should stay away from resection in these patients. And if we decide for surgery, again, don't forget the quality of the resection. We quite often overlook this also in clinical trials, but the local radical therapy is really the cornerstone of a curative intent treatment. And you can see here the overall survival and relapse-free survival rates according to the quality of the surgery. So the delay to surgery, surgical approach, extent of resection, nodal sampling adequacy, and surgical margin. And I think, again, you need a good surgeon to achieve these good outcomes. So moving from surgery to systemic therapy, should we give adjuvant or neoadjuvant? And I think first we should look at the aims of our systemic therapy. Well, the first aim is to increase the cure rate by eradicating micrometastasis, and this can be done by adjuvant and neoadjuvant therapy. But another aim could be to downstage the tumor and facilitate resection. Of course, this is neoadjuvant. Another, I think, benefit of neoadjuvant therapy is that you have an early readout of the efficacy of your systemic therapy. But of course, we also know that there is a risk of toxicity and that approximately 15 to 20% of these patients don't make it to surgery. And for chemotherapy, we know that PET-CR correlates with long-term survival. And now we also have the data, for example, for Checkmate 816, that this is true also for immunotherapy. I think for targeted therapy, we don't know yet at the moment. So moving to immunotherapy data, this is, I think, a very nice slide I borrowed from a colleague. In blue, the adjuvant immunotherapy trials with Empower 10 and Keynote 091 or PEARLS positive for DFS, but CCCZ BR31 negative. Checkmate 816, the only trial with neoadjuvant chemoimmuno positive for event-free survival and overall survival, and a multitude of clinical trials evaluating perioperative chemoimmunotherapy, with Keynote 671 also positive for overall survival. The other clinical trials don't have mature overall survival data yet, but I think if you look at the disease-free survival, they all go in the same direction. Of course, you cannot really compare these clinical trials. It's a little bit different patient population, a little bit different treatments, but I think in conclusion, we can say that at least neoadjuvant works and that perioperative also works, maybe adjuvant a little bit less. So should we give neoadjuvant or perioperative or adjuvant immunotherapy? And for lung, we don't have randomized clinical data. We have preclinical data that neoadjuvant is better than adjuvant because it sensitizes the immune system when the tumor is still in place. For melanoma, we have data that neoadjuvant and adjuvant, so perioperative is better than adjuvant, but we don't have, of course, the data for neoadjuvant versus adjuvant. So how should we move forward? And I think the big debate is still, should we give neoadjuvant or perioperative? But also we know that PET-CR is associated with improved outcomes. So can we predict we will obtain a PET-CR and maybe to escalate treatment in those not obtaining PET-CR? And how can we increase the PET-CR rates? And of course, to also take into account, especially if you look at the global level, the money, the toxicity, and the time investment for the hospital, but also for the patient. So neoadjuvant or perioperative immunotherapy, if you look at Checkmate 816 and Keynote 671, then 5-year overall survival is exactly the same, with more grade 3 or higher treatment-related adverse events for Keynote 671. If you look at patient-level data analysis and meta-analysis, then it seems that those without a PET-CR maybe benefit more from a perioperative regimen. PD-L1 negative maybe, and maybe also especially those with a major pathological response rate. But I think these are cross-trial comparisons and all kinds of statistical caveats, so I think we need clinical trials to really evaluate the best treatment. If you then go into more detail, we know that the less residual viable tumor, the better the outcome of the patient. And for example, if you look at Checkmate 816, those with 80% or more residual tumor left all died within 3 years. So it's also something to take into account for discussion with your patient after surgery. And as I stated, the PET-CR status may define the role of adjuvant. So this is a patient-level meta-analysis. You can see that those with the PET-CR do best. If you look at the box below, the MPR really seems to benefit from the adjuvant part. The PET-CR right upper part don't benefit, and no MPR also doesn't seem to benefit. So the authors of this paper suggested that we can use these PET-CR, MPR, or no MPR rates to either de-escalate to give only neoadjuvant chemoimmuno if you have a PET-CR, give adjuvant of perioperative chemoimmuno for those with an MPR, and escalate for those without an MPR. But I think these are all combined trials with all the caveats I just mentioned. We need clinical trials to prove this. Unfortunately, we have some clinical trials. For example, the ETOP-ADOPT trial is evaluating whether for patients, especially without a PET-CR, maintenance immunotherapy after neoadjuvant chemoimmunotherapy improves disease-free survival. Maybe we can also escalate, for example, add a vaccine. We have, for example, the Interpart 009 trial. So also those without a PET-CR are randomized to maintenance immunotherapy or immunotherapy plus the vaccine. So this trial will not answer the question whether we should continue the adjuvant immunotherapy, or maybe we can escalate with ADCs or other checkpoint inhibitors. For example, the TroFuse trial, pembrolizumab and sacituzumab tirumotecan compared with pembrolizumab, the Arian trial, zimberelimab versus sacituzumab and zimberelimab, also the NeoCOAST-2, the adjuvant part, but that's purely exploratory because that's not randomized. So can we predict who will not have a PET-CR? And we have some hints, I think, but we're not there yet. If we look at the Aegean trial, then those without ctDNA clearance almost never had a PET-CR, approximately 10 to 12%. However, if you had ctDNA clearance, your PET-CR rate was only 50%. So I think it's not fit for daily clinical practice, at least to predict the PET-CR. We also did some retrospective data together with some Chinese colleagues to evaluate the delta radiomic score, and it seemed to be associated with PET-CR. PD-L1, TMB, 4 gene signatures all seem to be associated, but I think it's not feasible, especially for TMB or 4 gene signatures, to do this in daily clinical practice. And if you want to start upfront by escalating treatment, you also need to take into account the turnaround time and the cost, etc., and of course whether it's prognostic or predictive. Maybe we can learn from our melanoma colleagues, but I think it's more difficult in non-small cell lung cancer. In a melanoma trial, they adapted the therapy based on the pathological response in the index lymph node, but I think that's easier for melanoma than for non-small cell. At ESMO, we also had a combination of ctDNA and radiomics, so from the Aegean trial. So they took the baseline scan and the scan just before surgery, and they calculated the delta L energy. So there was a shrinkage in tumor volume and a decrease in intensity. And if you look at the left, then especially the radiomics model was better than the clinical or even the clinical and radiomics model. However, if you also took into account the ctDNA, then the model even improved. So I think it's something, we have a hint that we can predict who will have a PET-CR. The only thing is this is based on imaging just before surgery. So maybe then in the end you're too late to escalate treatment. Other ways to improve in a neoadjuvant setting is, for example, by adding radiotherapy. And we have some phase 2 trials hinting that this could be possible. And I think especially the section trial, so only stereotactic radiotherapy to the primary combined with chemoimmunotherapy provided interesting PET-CR and MPR rates. But I think in the end we need to see whether the PET-CR and MPR rates caused by radiotherapy will have the same outcomes for micrometastatic disease compared with chemoimmuno only. Add another drug is also possible, and here I think the NeoCOAST-2, the datopotamab deruxtecan, durvalumab chemotherapy is maybe the most interesting, and I hope we will have a trial within EOTC evaluating this regimen in a randomized setting, because in the end I think this is all single-arm phase 2 trials, and we need randomized clinical trials and biomarkers showing which treatment for which patient. And to positive disease, I think it's a huge debate still. Should these patients have resection or chemoradiotherapy? And at least for EGN, we have granular data for N2 disease. 50% had baseline N2 disease. The majority had single N2 involvement, so indeed considered resectable. And if you look at the surgical and adverse event rates, but also event-free survival benefit was similar compared to the overall group for single, but also multi-level N2. And if you look at other clinical trials like the NADIM, the Checkmate 77T, and the NeoTorch, similar surgical benefits were found for N2 versus no N2. But I think that still doesn't answer the question whether we should give surgery or do resection if we have resectable stage 3 N2 positive disease. And the clinical trial is ongoing, so patients with stage 3 N2 positive non-small cell considered resectable receive 3 cycles of durvalumab chemotherapy, and they're still considered resectable. They proceed with surgery or chemoradiotherapy, and primary endpoint is EFS rate at 2 years. For me, I think it's more attractive, sorry Matthias, to go for surgery because you also have your early efficacy readout and maybe an option to adapt your treatment, but I am looking forward to these results. And making even a step further, can we make borderline resectable resectable? And at ESMO, we heard the MDT bridge trial. So patients with resectable or borderline resectable non-small cell, according to the MDT, were given 2 cycles of chemoimmunotherapy, and then they were re-evaluated. And if still considered resectable or became resectable, 2 additional cycles, and then resection and adjuvant durvalumab. And if not considered resectable, they proceeded to chemoradiotherapy and adjuvant durvalumab. Only 84 patients and only 28 borderline, so I think this is mainly signal seeking, and the trial is still ongoing. Borderline resectable was in half of the cases due to the T status, and then 1/3 due to the N status, and the others combined. But I think it's reassuring that at least almost all patients got radical treatment. The majority could proceed to surgery, and if no surgery, they receive chemoradiotherapy. But I think we need long-term data to see whether the chemoradiotherapy after induction chemoimmunotherapy caused toxicity like pneumonitis. From the unresectable disease setting, we have data that concurrent chemoradiotherapy and immunotherapy combined does not provide any benefit for the patient. So I am looking forward to long-term data to see whether this strategy is feasible in the borderline resectable setting. Or even taking it a step further, can we make unresectable resectable? And this is the LungMate 013. So stage 3B to 3C non-small cell, and approximately 2/3 at stage 3B. No information-wise stage 3, so based on the T on N. They received induction chemoimmunotherapy, and if resectable, were then randomized to surgery or radiotherapy. And if unresectable, they were treated according to the MDT. Just over half of these patients became resectable, and exactly half were randomized to surgery or radiotherapy. And there seemed to be an EFS benefit if these patients with resectable non-small cell received surgery. I also understood, but I'm not a radiation oncologist, that there was lots of critique for the radiotherapy. So maybe Matthias can in the end comment on this. We have also some retrospective data and Chinese prospective studies. So a multi-center cohort study based on unresectable T4 or the N2 or N3 status. Over 100 patients, neoadjuvant chemoimmunotherapy, and 3/4 of these patients could undergo resection. But I think good PET-CR, MPR, and EFS rates, and no differences for single versus multi-station N2 or N3. But for 2 Chinese studies, conflicting data, both trials had approximately 100 patients. And in one trial, only 25% underwent surgery. So I think that's quite disappointing. And in the other, 50%. I also saw some retrospective American data suggesting that some of these patients really are harmed by such a strategy. So for me, this is really something you should not do in daily clinical practice, but really reserve for a clinical trial. Some targeted therapy, well, for EGFR, we all know that standard of care for resected stage 1B to 3 non-small cell with a classical EGFR mutation is optional chemotherapy and an adjuvant osimertinib for 3 years with a 5-year overall survival of 85%. The larger benefit is with the higher disease stages, and there's also a protective benefit for the CNS. However, if we look at the first generation EGFR TKI in the emerging trial, no benefit. So it's really the 3rd generation. But if you then move the osimertinib to the neoadjuvant setting, then I think the data is quite disappointing with low PET-CR and MPR rates, and I think long-term benefit not shown. So can we improve? At ESCO, we had the NEO-ADAURA trial. So patients with resectable non-small cell, classical EGFR mutation were randomized to neoadjuvant osimertinib with chemotherapy, osimertinib monotherapy, or chemotherapy alone. They didn't look at TP53, which is, I think, a disappointment because we know these patients respond well to TKI. And I think with all these three single-arm phase 2 trials shown on the previous slide, I think osimertinib monotherapy is not sufficient. But if you look at the percentage of patients going to resection, that was, I think, quite similar for the OSI and chemo-OSI, a little bit lower for only chemotherapy, and percentage R0 resection also quite similar. If you look at the percentage of the MPR and PET-CR, I think quite disappointing that the adding of chemotherapy to osimertinib did not increase the PET-CR rates. Long-term outcomes are not available yet. There seems to be a signal that for chemo-OSI induction, there is a better hazard ratio for event-free survival, but it's not mature yet. And I think also important, the majority of the patients in the osimertinib mono neoadjuvant part did not receive adjuvant chemotherapy, and maybe these patients still also need chemotherapy and not only osimertinib. It seems that this regimen can at least downstage resectable N2 positive EGFR non-small cell lung cancer. Approximately 1/3 of these patients had N2 disease, and downstaging occurred in 50%. But I think in the end, we don't know whether these patients really need the neoadjuvant part or just can get the resection and the adjuvant part. So how to improve for resectable EGFR positive non-small cell? We can add maybe amivantamab, but also has some immune modifying properties. And this is done in the investigator-initiated NeoPredict EGFR trial with neoadjuvant EGFR TKI and amivantamab. As for immunotherapy, we can add ADCs or other drugs, and several trials are ongoing. But I think especially in the targeted therapy space, we need translational data to really inform us how to move forward with the treatment of these patients. Unfortunately, a window of opportunity trials is ongoing to evaluate the drug-tolerant persister cells after neoadjuvant osimertinib. Also the NEO-BIO-ADAURA for resistance mechanisms, and another trial with neoadjuvant ctDNA-based escalation treatment. Couple of sentences about ALK. We have now 3 randomized clinical trials, the ALINA with adjuvant alectinib or chemotherapy in ALK positive non-small cell, the ELEVATE with enzartinib or placebo, so quite similar design, and the biggest difference is that in ELEVATE optional chemotherapy was allowed, and the E4512 with adjuvant crizotinib. And as you can see in the Kaplan-Meier curves, both in ALINA and ELEVATE, there is a DFS benefit for adding the ALK TKI. I didn't show it on the slides, but if you look at ELEVATE, the hazard ratio for DFS was the same for patients receiving adjuvant chemotherapy or not. So maybe in ALINA they were right by not giving adjuvant chemotherapy. But I think in the end, you want to improve overall survival, not only DFS. So we need long-term outcomes to really see whether we can skip the adjuvant chemotherapy. We also have some neoadjuvant ALK data, so the ALNEO and the Nautica. And it's small single-arm phase 2 trials, but it seems that PET-CR and MPR rates with a neoadjuvant ALK TKI, alectinib in this case, are a little bit better than with osimertinib. But maybe that's because these drugs seem more potent. Also, if you look at the PFS in stage 4, ALK TKI provide better results than osimertinib for EGFR. But we have many unanswered questions in oncogene-driven non-small cell. As I touched upon, do we need adjuvant chemotherapy? Can we give better targeted therapies? Do we need 2 years, 3 years, or even longer treatment of targeted therapy? The neoadjuvant part. What about the small tumors with an aggressive histology? What should we do at progression? Can we re-challenge these patients? And can we use MRD to guide our treatment? So we have some trials ongoing. So the target trial is, I think, an Australian trial evaluating 5 years of osimertinib. But I think this is a challenge. But if you look at ADAURA, then approximately 1/3 of the patients discontinued OSI due to adverse events, and approximately 5% had cardiac toxicity in advanced non-small cell. And I think you want to avoid cardiac toxicity in a curative intent setting. We also have already a trial with aumolertinib in stage 1A with aggressive features. So these patients were treated with aumolertinib observation, and it is suggested that adjuvant aumolertinib improves at least the disease-free survival for these patients. And a trial with adjuvant osimertinib is ongoing. And multiple other trials are ongoing. So we have the Horizon platform trial. In the end, multiple arms were dropped and only alectinib is left. The Nautica biomarker-driven trial with multiple targeted therapies. An IND trial with periopnurasib. I think the development of that drug has been discontinued, so I think this trial will also stop. And Libetto trials for RET-positive non-small cell with neoadjuvant and adjuvant selpercatinib. But I think we shouldn't forget that some of these oncogene-driven non-small cell lung cancer are also sensitive to immunotherapy, especially KRAS, and several trials are ongoing or in startup. So my conclusions and take-home messages, I think very important, we need adequate imaging and functional workup. These patients should be discussed in an experienced MDT. And I think, personal opinion, if immunotherapy and resection are considered, then I think the neoadjuvant or perioperative therapy are best. We need trials where to escalate, but also to de-escalate. Maybe we can convert borderline or even unresectable to resectable, but we need more clinical trials. And adjuvant osimertinib and alectinib are standard of care, and more data are needed for other approaches. Thank you.
Thank you, Lisa. That was really excellent. I think there might be questions from the audience. If not, I can ask a quiz question. We discussed today in the tumor board about perioperative neoadjuvant. It's also a question of what is possible in the different countries. What about mutated patients? Would you treat them now in clinical practice with neo-Adara? I mean, the results were sobering, but still, we're all not very happy with the approach we have left.
Yeah, I think for me, well, I'm Dutch. We're really have to stick to reimbursement criteria, so I cannot do it. Mm-hmm. But for me, I think if you have a borderline resectable tumor, and I know it's out of scope of the clinical trial because they had to be resectable, but then I would like to try the neoadjuvant osimertinib chemotherapy to make the tumor resectable. I'm not quite sure whether you really improve the long-term outcomes for these patients.
Yeah. So we have no questions online, I understand, no? Anything else? Good. Thank you very much. Exciting times. And now it's becoming even more exciting about the future. We will hear about the role of AI in oncology care today, or most probably more what will come in the future. And Professor Daniel Truhn from the Technical University in Aachen, Germany, will present this. Thank you for coming.
Thank you very much for the kind introduction. Yes, so I'll be speaking about AI in oncology care today. These are my disclosures, and after we have that behind us, I want to also start, like Lisa, with a bit of history. Neural networks have been astonishingly good at differentiating different classes of images, right? So you can try to beat the networks yourself. There's one odd one out in each line. I guarantee you the neural network is faster than you. So the transition towards medicine was not that hard, actually, because there are some disciplines, radiology, for example, or histopathology, in which digital images are available as well. And basically, it's the same game, right? It's differentiating different medical images into different classes. Cancer, no cancer. And this guy back then in 2016, almost 10 years ago, said we should stop training radiologists. At that time, I was doing my residency. I was not happy about that, even more so because I thought he has no heart for radiologists. Even more so because he was comparing us to the coyote who was already over the edge and hasn't realized that he will be falling soon. Well, 2021, there was nowhere near the case. There were almost no deep learning algorithms in the clinics. The decisive question is, how will it look like 5 years later, so in 2026, say next year? Well, there are actually some cases in which radiologists can be replaced. If you have sufficient amount of data available, millions of images, if the data is 2D, and if the data is highly standardized, like in the mammography screening setting, that works really well. So you can do a randomized trial and you can compare the conventional way of diagnosing or looking at the images by 2 radiologists versus the one where you have 1 radiologist and 1 AI rating the image. And it turns out that the AI-supported mammography screening pathway is more or less the same as the conventional way. It results in a similar cancer detection rate. Now, this was about doing something that we can do as humans as well, right? Mimicking us. Now we are going towards image biomarkers, so seeing what we cannot see, so to speak, so getting more out of the images. There are some image biomarkers which we have figured out as humans ourselves. For example, again, the example of mammography, we know that in very dense breasts, so breasts with a lot of fibroglandular tissue, cancer can, so to speak, hide, and it's harder to assess. So we would like actually these kind of images, or these kind of patients rather, to undergo additional MRI examinations, because this would actually help the patient discover cancer earlier. So that's actually the recommendation by the European Society of Breast Imaging. Of course, it's not always done due to cost reasons, but if you were to do this, and if you were to send those patients towards the intense MRI screening procedure, you would actually save lives, and not few lives, but you would save 9 additional lives per 1,000 women invited. So this is an example of an imaging biomarker which we have discovered ourselves. Question is, can AI do similar things, or can AI do even better things? So giving the AI millions of images without like the previous classes found out as by humans, but just with the follow-up if there's cancer or not. And then letting the AI decide if it, even before the cancer becomes apparent, can differentiate those patients into different classes. Turns out that it can do that very well. Again, the same scheme as before. If you allocate, or if you let the AI decide whom to send to the intensified MR screening and whom to let the conventional screening continue, then you will find out that actually you can save even more lives. This procedure is 4 times more efficient in terms of cancers detected than the conventional A, B, C, D bi-rate scoring. So very high benefit actually for AI. So this was radiology. Now there are also other imaging modalities, histopathology, for example. And as you all know, I don't have to tell you this among all the people, medicine is becoming ever more complex, right? When 15, 20 years ago, you basically provided administered chemotherapy. Now you have a very differentiated pathway of deciding, according to the genetic signature of the tumor, what therapy to give. We have heard about that in the previous 2 presentations. Now, the first indication of that you can actually use AI to get some information out of that is actually was done by my colleague Jakob Carter, and it's actually not hard to understand, because if you have a genetic defect, that will also turn out to somewhat affect the behavior of the cells, right? And they will look different in the histopathology image than under normal circumstances. So basically, it's the same setting again. You have a bunch of images, and you have to find the odd one out in order to identify the genetic effect. And that works really well. So you can do that. This was 2019, and you could, for example, extract MSI, so microsatellite instability, just from the histopathology images. And it works really well. And it's also applied now in clinical study. This is clinical studies. This is one of the first clinical studies in which this is actually used. So when you do the conventional pathway again of just randomly allocating patients into those who receive the new drug versus the standard drug, the advantage is, well, not very suppressive, to say the least. But when you then use AI again to differentiate the patients into those groups of people who might respond to this treatment and those groups of people who might not respond to this treatment. So you have trained the AI before, and then you do the differentiation. And now you do the same again within those 2 groups. Then you see that the survival benefit is actually much higher now, over 2 months, whereas it was less than a month before. And in the group for which the AI has not recommended to administer the drug, the survival benefit is actually lower, actually negative. So it's highly desirable in some cases to use AI. So now we have seen that you can use it in both imaging modalities like radiology and histopathology. But as I said, and I'll stress that again, medicine is complex, right? So you have more than just the images. You have the genetic data, you have the clinical data, you have all the history of the patient, and activity data, laboratory data. And all of this cannot be analyzed with the conventional neural networks, the convolutional neural networks, which have been used to analyze the images. Now, the stage has been set for foundational models because they are really good, and I'll show you how these are trained, at analyzing data for which you have to solve more broader classes of problems. The way in which these are usually trained is as compared to the conventional pathway in which you have a lot of data and then you pay a medical doctor, say a radiologist, to label this data, to get your labeled data. This is a way of burning money if you want to do it on a large scale. If you on the other hand want to use, I'll just stop that for the moment, want to use data that you can find on the internet, text data, textual data, and use that to train the models, then what you can, for example, do without actually labeling the data, you can take the text and you can ask, can you still understand me, more or less? Okay. You can ask the model to basically reproduce the text, or predict the next words in the sequence. So you have this sentence which you picked from the internet and you ask the model, how does it continue? This is all the model sees, and then it makes a prediction. In this case, the prediction is correct, right? Or at least partly correct. Is the change in the leaves, it says, but rather the sentence was in color. And so it just keeps the correct part. And by doing this over and over again and just keeping the correct part and learning what the correct words are to continue the sequence, those models learn much about the general setup of the word, learn more about than just continuing sentences, but they also learn a bit about how the word works. And to drive this home or to visualize this, let me give you an example, which is a video generative model. They work very much in the same way. So we have different frames of videos, and you have to predict the next frame. And then again, based on that, you have to predict the next frame. And these models, as you know, I'm sure you have seen that, are really good at generating videos. So these are videos that the model has never seen before. You just have to prompt it with a prompt, simple prompt like this, and it can generate these Italian landscape videos or these video of a whimsical snowy gingerbread village. Now, to give you a feeling or to show you that actually these models learn more about the physical reality of the world than just reproducing and predicting the next frame, you can also ask the model to start with the video on the left side and end with the video on the right side. And you will see that it does that in a rather, I'd say, intelligent way. So it hides the scenery as realistically possible as you can probably do within the soul setting behind the wall. So it learns something about what you can see, that there are lines of sight, etc. And I think it's quite impressive. And that's exactly what is needed when you want to go towards medicine and have all the complex data. You can't treat, or you can't train a model for each and every application case. You have to have a model which can understand the data as a whole on a general level. Coming back to the historical evolution. So in the first, 15 years ago approximately, we had these neural networks which were really good at specialized tasks. And there are many publications about that. I showed you one in which these will actually come into the clinics. Then around 2 or 3 years ago, ChatGPT took the stage, and the development now is much faster because many more people are working on that. And there are many applications in which these can potentially make our lives easier, more efficient, and potentially also diagnostics more accurate. So these models now excel at simple medical tests like the USMLE exam, right? But okay, this is a multiple choice test, and now they are at the level of our best students, fair enough. The interesting part about it is, as I said, that they can somewhat reason about the data that you give them. So they can think about the data, and that they provide a kind of natural interface to the data. This is helpful for us as medical doctors, right? Because we can now provide it with the data, and then it can help us reason about that data. And it's also helpful for patients and medical doctors alike if you have a direct interface to the data. If you don't have to deal with complicated informatics APIs or informatics interfaces and don't have to deal with first writing a program to directly access the data. And there are many thousands of publications actually. I just show you some example publications. So you can, for example, let the model solve, going one step further beyond the multiple choice case, solve patient vignettes. So if you provide them with a complete description of a case, patient case, they are at the level of medical doctors. And also in the clinics, so taking direct patient cases from the clinics, that's what this publication is about. Again, they are at the level of senior physicians. And they are now even so good that they exceed us as humans in some instances where we would not have expected that before. For example, in treating mental illnesses, in treating depressive disorders. They, in this publication on the right, they actually are better than humans at treating people. So in contradiction to what we always hoped, that we would understand the models like through different means, like these nice fancy images where you have these heat maps, it's now the case that these models are much better at understanding us, apparently, than we are at understanding those models. Now, the next important step then is to go towards agent-based AI, to use these large language models and let them kind of loose, let them perform tasks as well. And the basic idea is that you take an LLM, large language model, which can basically, as you all know, answer questions, but then let it repetitively work on a problem. Let it use tools, for example, analyze the radiological images, and then reason about the data and go through the PubMed literature, and then again reason about the data and come towards sensible conclusions. And this is what we actually did within this publication, together with, or actually led by Jakob Carter in Dresden. We developed an autonomous AI agent which can help us in clinical decision support in oncology. So, for example, you could then ask it something like, what's the best treatment for a patient with this genetic disorder or genetic constellation and who has had this history? And then the agent goes about and reads through the guidelines, reads through the literature, checks if there's some new scientific results which we can use. It might check the radiology model, it might check the pathology images, and etc., and go through all of the medical data. And then in the end, it comes back with the result, which is the best treatment is this specific drug for up to 14 cycles. And it works really well, as we show in this publication. However, there's still work to be done. And again, because I always like it when something can be visualized, and I think it's a shame that we don't have sound. Let me try to get it on. But this is a scenery that took place in, I think, LA at 3 o'clock in the night and filmed by a resident. What you can see, but unfortunately not here, I think, is that this car is backing up. It's a Waymo car, so it's a self-driving car, which is prompting this car, and all those cars are trying to park, right? To back up, and prompting this car to honk, to back up. So this was the constant sound that these people were given at 3 o'clock in the night. So not everything is perfect yet. So a lot of things to do. In particular, when it comes to medicine, right? We want to be as close to perfect and checkable answers as possible. Because if you ask ChatGPT, for example, and admittedly they're getting better at this, but still, if you ask it, how did you come to that conclusion? It will give you something like some link which might or might not work. It might just tell you, yeah, just trust me. Or it might even tell you something like, oh yeah, you're right. It's very sycophant. It likes to please you. It was trained in this way. And actually, I tried this out, or actually some other guy tried this out a few years ago. And if you ask it, what is 1 + 1? It gives you 1 + 1, it gives 2. And then if you ask it, isn't it 3? It tells you, I apologize. Apparently 1 + 1 is indeed 3. Now, I said that they are getting better at this, right? Because I tried it again. And then I asked, what is 1 + 1? It answers 1 + 1 = 2. And know that it's already putting a smiley behind it. So I think it's knowing what's coming. And then I ask it, are you sure isn't it 3? And say something like, haha, nice try. But yeah, I'm pretty sure 1 + 1 = 2. Unless we are talking about some wild new math, or maybe a metaphor, like one idea and another idea is a big idea. And then it's starting to mocking me, what context are we in, math class or philosophical debate? And it's also not backing down. I said, no, I'm positive, it must be 3. And it says, I see you are confident. I got to say 1 + 1 = 3. If you say so, are we talking math or maybe babies? Because in babies, yeah, 1 + 1 sometimes does equal 3. Sorry, relationships, of course. So it has some humor, I give it that. And it's getting better. but still not perfect. Now, also again, I try to put the sound up, because the important thing is, in particular with OpenAI, can I trust them with my data? I don't know if you can hear that. I'll try to.
You have an incredible amount of power at this moment in time. Why should we trust you?
You should.
So she was asking, you have an incredible amount of power. Should we trust you? And he says, no, you shouldn't. And that's Sam Altman. That's the inventor of OpenAI, right? So you do not want to give data to ChatGPT, in particular in today's times. A better way of doing this is actually having dedicated solutions that you build yourself. So that's, for example, what we do in one of my startups. When you ask it a question, it gives you an answer, and then it gives you also links where you can actually then check on the provided documents, and it notes down which part of the document it used and which part of the document the information is referring to. That way you get the information quickly, but you can still check where it comes from. I think that's very important when going towards AI-assisted medicine. Now, coming back to the beginning, this is the same guy that said radiologists will be obsolete in 5 years. I also showed you a video about self-driving cars, because this guy said 1 year before, we will have self-driving cars in 2 years, and well, the reality is 2025, radiologists are still driving to work. And there are still some remaining challenges coming to the end of my talk. So in the real world, we have all this data distributed among the different clinical systems, and they are not accessible, not easily accessible. So you have all these different systems, potentially, which are, well, hard to be likable, I'd say. Ideally, you want to have some way of having a standardized way of accessing these platforms, right? Some standardized FHIR, DICOM interfaces. Because if you had that, then you can build apps based on that. And that would be easy, then really easy for all of us to deploy. Unfortunately, that's mostly not the case. And to drive, again, this home, and this is, I think, my last slide. So the usual way in which we develop AI models is you work together as a group. So you have the PhD student, then you have the professor who's maybe providing the ideas or giving unwanted advice. You have the clinicians who's giving a lot of input, the postdoc potentially. Finally, you have to do the validation in the clinics, and then you also need to work together with the IT department, right? And that's not always working as you intended. Thank you very much. Are there any questions?
On one hand, it's very exciting, but also quite sobering to see that AI might be able to even replace the human touch of our profession. So I think that's scary, to be honest. Do you want to comment on this?
I agree, and I don't like this. So although I'm working in AI, and in principle, I benefit from the fast progress, because then I can do more impressive research or whatever. I would like the progress to slow down, because that's not what I would like to see, that we have soon models which are much better than us. And that's also a dangerous thing in the wrong hands. And unfortunately, nowadays, most of the power, so to speak, like computational power, is in the wrong hands, in my opinion. So you have a lot of billionaires who are determining what will be happening with those models. And that's not what we should strive for as a species and whole.
Thanks for an excellent presentation. How do we make that a business model and the economics right? I mean, because all these elements are effectively learning from us. So we publish, we have been paid for SNF, DFG, and now we have AI learning effectively for free. That can be books, that can be articles on the internet. So how are the kind of content generators in the very beginning being paid for their work, which is not just called it sucked up by some algorithms, agents flying around and learning from these sources?
Yeah, very good question.
And who will generate evidence or kind of data in the future if there's no payment model behind it?
Yeah, exactly. in the beginning, you weren't paid. So basically, OpenAI just scraped your text, just took your text. And famously, there was a lawsuit by, for example, the New York Times, who found out that they used their text, and they sued them. In the end, I think they settled to now cooperate with them, because that's more profitable to them. And also, I think Anthropic, the creator of Claude, which is similar to ChatGPT, they had to pay a few billions, but not many billions, like 3 billions to content creators, like authors. So it's shifting more towards actually paying the ones providing the training data, but you can be sure that there are many like companies just using the data and not caring about paying the content creators. So it's a problem, I admit. Yeah.
What is your expectation? Who's going to generate kind of high quality data in the future? If there's if you know, well, I'm investing work, and that work which I'm generating might make me jobless in 2 years' time, and I'm not even paid for it.
Yeah, good question. I think part of it will still be humans generating the data for the foreseeable future, assisted by AI, say agents, for example, because you can work admittedly more efficiently with these, with ChatGPT, for example. For the foreseeable future, I think we will still be generating the evidence irrespective of whether or not they will pay us, right? Because that's just, we will still get our grants, we'll still do the things in the way we have done them before. Humans are much too slow to adapt to the technical evolution, I think.
Markus?
Yes, thanks. Fascinating talk, and I agree that it's a great tool for integrating large amounts of data and coming to conclusions that probably exceed what we as individuals can capture. I took the opportunity to ask you at lunch, but how about the somewhat low complex tasks? I mean, it's said we have a GP crisis, we don't have enough doctors to take care for all the aging population. And my feeling would be that if we can get some AI support by accomplishing maybe less complex tasks, by having chatbots for patients to do the baseline work and then get together and spend more dedicated quality time with the patient on topics, that would be really helpful. And when I'm listening to these talks, I always see these things that leave me in awe, but I see very little practical applications, and I just wonder where we stand there.
I agree with you. I mean, I have to show these shiny things, right? It's what the future, what many people think like will the future be looking like. But the way to go in the near future is exactly this, providing support for the boring tasks, for like writing documentation, having an AI available which you can talk to maybe on your way from the surgery to your doctor's room, and then just already note down the report in prosaic form, and then have in the background have the report written ready already for you, so that you can copy it. This is also something that we are working on, and I think many people are overlooking, or many companies are overlooking that, because they always want to solve the big problem, and it's easier to get a lot of funding if you if you say you will replace the doctor in the end. But actually, these small problems are more worth putting effort into, and that's also what we are doing in our group. Unfortunately, though, there you have to deal a lot with the IT department, and that's, as you saw, quite painful, literally, sometimes.
Thank you very much. So we will come back now to the reality and speak about pathology, and it's my pleasure to introduce to you Dr. Jan Rueschoff, who is attending in the Department of Pathology and Molecular Pathology, and give us an update in lung and thoracic oncology. Thank you very much.
Yeah, thanks a lot for the kind introduction. I'm happy to have 10 minutes for an update in molecular pathology, what is going on in molecular pathology. I want to give you a little bit of background. So molecular testing in pathology is done in two subunits. The one is the Foundation 1 lab, which is based in Schlieren and offers 3 bigger NGS tests and is headed by my boss, Holger Moch. On the other hand, my colleague Bettina Sobotka and I leading the molecular pathology subunits, which are basically all non-Foundation 1 tests. And we're doing this in here in the center, and we're offering NGS tests, but also other tests, clonality, infectious, MSI testing, and lots of FISH testing. And to give you a little bit more background, so my colleague Bettina Sobotka and me, we took over this department in 2022, and we did really a lot of change management in the last 3 years. I just want to briefly give you an idea what we all changed in the last 3 years. We merged basically we found in 3 years ago 2 separate teams. One was doing mainly Sanger sequencing and one was doing small NGS panels. We merged these teams. We built new leadership structures. We relocated the whole subunit. You see pictures here. We automated report generation. We updated the report layout. We updated the homepage. We updated the order forms from 14 separate forms to 1 form. We have 3 approved innovation pools application, and we switched from mainly Sanger sequencing 3 years ago to NGS sequencing. You see the numbers here. We almost do no more Sanger sequencing. And for the lung, about 2 years ago, we changed the lung algorithm, so our lung testing, and with the help of this instrument, this is called Genexus, we made the turnaround time going down from 6 days to 2 days for this smaller 50 gene lung panel. And this will going on. The OK Plus, which a bigger panel, will also shortly go onto this machine, and the turnaround time will decrease. We also updated clonality analysis. So we've done a lot of things, but what's next? And what's next is this lovely machine, which is called NovaSeq X Plus. It's like the Ferrari of sequencing machines from Illumina. And what makes this machine so sexy, so to say, and these are the decreasing sequencing costs. And when you look at this, the y-axis, you have the cost per 1 million reads. And when you look at the usual suspects, we have all of them in molecular pathology running. You're seeing the costs are dropping. And we have the NovaSeq 6000 in Schlieren running. But even compared to this one, with the NovaSeq X Plus, the cost for sequencing is going down by 3 times more. And this is quite impressive. And this enables us to have new sequencing options. And this is what we plan to bring into routine diagnostics next year. So we want to offer whole genome sequencing, whole transcriptome sequencing, so bulk RNA sequencing. And what will come more or less as a bystander is pharmacogenomics and metagenomics. Pharmacogenomics we started last week. in close cooperation with the Institute of Pharmacology, and we are offering the largest pharmacogenetic panel in Switzerland, which is really great. And also with metagenomics, we can much more reliable detect infectious disease. So to give you a glimpse what is happening here, so when we talk about targeted sequencing, we usually have this 100 kb amount of sequencing data. This is signaled here as this small dot. When we talk about whole exome sequencing, we're talking about 60 megabases, which equals this dot. When we talk about whole genome sequencing, we're talking about this amount of data. And this is really so, as you know, one genome is 3 billion bases. We want to sequence this 100 times. So this is giving us lots of data. So per patient, we're talking about around 200 gigabytes of data we have to analyze, but we also have to store. And this is really challenging for IT and IT infrastructure, but we are there, and give you a glimpse of the workflow. So what we need for that is a normal sample and a tumor sample. Both will be sequenced with whole genome sequencing. The normal is mainly for the reduction of germline variants, but also for this pharmacogenomics HLA typing. So, and with the tumor, we will do the usual somatic variant calling, CNV, but also signatures, fuse metagenomics. And for the RNA sequencing, we will do the variants, bigger CNV calling, signatures, fusion, and far down the road, we can also do neoantigen prediction. We published this three months ago, and we started with the melanoma cohort, and we sequenced side by side 100 melanoma samples with the same, so the same aliquot sequence by Foundation 1 and whole genome sequencing, and we're getting the same results. Just briefly to mention, we also introduced this year a digital PCR platform, which is a cheap, fast, and very sensitive way to do monitoring of, for example, ESR1 and BRAF mutation from blood. And as I mentioned, we only have one order form, and we have now added the opportunity to order whole genome sequencing. It's not fully in diagnostics, so it's only research use only right now. We added the dPCR MRD testing and the pharmacogenomics. And with this, I'd like to thank my whole team, and I'd like to thank you for your attention.
Thank you very much, Jan. Looking forward to have this new machine in our garage here at the University Hospital. I would suggest we move maybe to the case. You can comment then later together with Dr. Boos. Welcome. And she will give us a case from our Molecular Tumor Board, where Dr. Rueschoff is also heavily involved, a patient case. Welcome, Laura, and thank you for presenting this.
Thank you very much for giving me the opportunity to present a case. It's going to be a case in the field of lung cancer from our Molecular Tumor Board. So this is a 75-year-old male that was diagnosed with adenocarcinoma of the lung in January 2022. It was primarily metastasized to the lymph node and the bone, and his initial molecular testing showed an L858R mutation in the EGFR gene, classic EGFR mutation. Also an EGFR amplification with a copy number variation of 10, a MYC amplification, a EGFR low-level fusion. The tumor was PD-L1 negative, ALK negative, ROS1 negative, KRAS wild type, and BRAF wild type. As per the then standard of care, the patient was started on osimertinib, systemic anti-cancer treatment, and was irradiated to the painful bone metastasis in his right shoulder. His first staging showed a partial remission. Some months after, there was again an oligoprogression to the bone, which was again irradiated, and the patient was treated beyond progression with osimertinib. What else did we do at this time? We also searched for resistance mechanisms, which we should be doing at the time of progressive disease under targeted treatment. And we did this on a tissue biopsy as per the gold standard, as opposed to a liquid biopsy. Oops, sorry. What resistance mechanisms do we expect under first-line osimertinib? We see here two different data sets. On the left-hand side, a more heterogeneous tissue-based and plasma-based data set. On the right-hand side, a more homogeneous data set, plasma-based from the FLAURA trial. And as we can see in both data sets, the MET amplification is a very important resistance mechanism. As you also see on the right-hand side, because we also have tissue, we can also see the transformation to small cell lung cancer. How do we test for resistance? As I said before, ideally we use a tissue biopsy because by definition in a liquid biopsy, the lack of something is not a proof. And also we can assess for morphologic transformation. Furthermore, we conduct an NGS where we can see somatic mutations, MET and HER2 amplifications, fusions and exon skipping lesions. We then compare the results to the pre-treatment biopsy and thus identify the resistance mechanism. What happened in our patient? We conducted the biopsy from the primary cancer. We found the MET amplification fitting to the resistance mechanism under first-line osimertinib. At the time of conducting the biopsy, it was only oligometastatic, so we didn't, oligoprogressive, sorry, so we didn't have to change the systemic anti-cancer treatment. A few months after, however, there was a diffuse metastatic spread. So we confirmed, yes, it's still the MET amplification that's the culprit, it's still the driving factor. And then we discussed which systemic treatment options do we have for the second line. At this time, we had amivantamab plus chemotherapy as per Mariposa 2. We had the chemo-IO VEGF inhibitor as per Atlas, and also osimertinib plus capmatinib as per case reports. The patient had tolerated the osimertinib very well, wanted to keep this, so he was started on osimertinib plus capmatinib and achieved a complete remission in his first staging thereafter. 4 months later, however, there was a single metastasis in the liver which was resected. Histologically, it was consistent with the metastasis of the non-small cell lung cancer. And in the molecular profile, we still saw the EGFR L858R mutation, the classic one. And we saw a new EGFR mutation as well, I744M, with a BAF of around 17. So this is a rare EGFR mutation. The question was, what now? So we went into the databases, the uncommon EGFR mutation database, which contains 1,245 patients, none of whom have this alteration. In the MyCancer genome, we saw 6 cases. And in OncoKB, looking also for actionability, there was one alteration that contained this location, but not this specific mutation. The alteration that contained the mutation the location was pathogenic. We looked further because at this point, the patient has 2 EGFR mutations that qualifies as a compound mutation. And the data on this is limited. However, looking at all the collected data in this very comprehensive overview, the individual case studies and preclinical data that we can use suggest afatinib as an option in this situation. We continued our search and also found a case report where a patient that has an NSCLC with specifically this EGFR mutation was treated in the first line with gefitinib and had a stabilization of disease. We took all of this information back into the Molecular Tumor Board and discussed. Is this really a resistance mechanism? We do not know. The data is limited. It would fit because it came up at the time of progression, so potentially. What would we do if we had to change the systemic anti-cancer treatment? At this time, we didn't have to because it was, again, an oligoprogression. The same regimens as before, amivantamab plus chemotherapy, then also the Atlas regimen, also gefitinib as per the case report, and afatinib as per the compound mutations. What happened next to our patient? He had repeated oligoprogressions, one in January 2024, which was irradiated, one in June 24 to the adrenal gland, also irradiated, one in February 2025 to the bone, again irradiated, and in May 2025 to the lung, which was resected. All this time, the patient continued on osimertinib capmatinib. Histologically, I'm not showing this, I'm telling you, it still fit to the NSCLC primary. From the molecular profile, we still saw the L858R, so the primary driver. We still saw the c-MET score, but we didn't see the new EGFR mutation anymore. So the question is, what role did it really play? At this point, we went back into the databases and also in preparation, of course, for this case presentation. The uncommon EGFR mutation database has now 2 patients more still. None of them have this specific mutation. In OncoKB now, the mutation is curated as likely neutral, which also explains why it's not anymore in the MyCancer genome database. So looking back, we have to think that most likely it wasn't a resistance mechanism. And that would also make sense with the case, the course of the disease for the patient, because the disease didn't pick up speed, right? He kept on having these repeated oligoprogressions, however, it didn't pick up speed. So that makes sense because you would expect that a clonal, strong pathogenic resistance mechanism would do this. I chose this case because I wanted to highlight that MET amplifications are classic resistance alterations under first-line osimertinib, that in case of progressive disease under a targeted treatment, a rebiopsy should be taken. It should be tissue, ideally, as opposed to liquid. I wanted to highlight what the work in the Molecular Tumor Board looks like behind the scenes if we do not have guidelines, if we're looking at what evidence can we find. Also, AI might be an option for this in the future because you can imagine this took us hours to find all of this. And of course, molecular oncology is developing rapidly and continuously, so it is worth to check again if the clinical course suggests it. With this, I conclude. I'm happy for any questions.
Thank you very much for a very interesting case. Other questions? If not, I'm happy to introduce the next speaker, not necessary, Professor Schmitt-Opitz, Isabelle, giving us an update on surgery. Isabelle.
Thank you very much. Maybe just to mention that the Molecular Tumor Board happens in our institution also once a week, like the Lung Cancer Tumor Board. So it's my pleasure to give a little bit of update. I will try to stay in time and maybe skip things that have been already presented. I have a few disclosures. None of them have any conflict of interest. So I will start with the first part, which is about screening and diagnosis. We know the benefits of lung cancer screening in the meantime, and we have here at the University Hospital Lung Cancer Center a screening program because at this stage in Switzerland, it's not reimbursed to do broad lung cancer screening. We have, in the meantime, also we have included into these screening programs current and former smokers between 55 and 74 years old with a history of minimum 30 pack year smoking and with a predicted 6-year risk of lung cancer of 3% or higher using the PLCO algorithm. And then in the follow-up, once we've done the CT scan, we use the Lung-RADS criteria for assessment. 426 participants have been included so far. And approximately two-thirds of the participants were active smokers at the time point of screening. We were able to detect with this 3.7% of cancers, most of them being lung cancer in all broad and different stages of the disease. So these screening programs, they bring up new detected nodules, and we have as the first institution in Europe been able to have the robotic bronchoscopy program together with our colleagues from pulmonology, where we are able to access these little and tiny nodules even in the periphery with a high diagnostic yield. We discuss all our cases or challenging cases, unclear cases in an interdisciplinary lung nodule board. And on these pictures here, you see the team from thoracic surgery and pulmonology who are in charge of the robotic bronchoscopy program. Since the implementation last year in July, we have seen a relevant stage shift in our cancers with a high increase of stage 1 lung cancers. We are offering also a very particular approach in thoracic surgery where we perform a so-called one-stop shop. Patients who are a very high likelihood of having cancer, they undergo in one anesthesia the biopsy with the robotic bronchoscopy, eventually marking of the nodule if it's subsequently resected and difficult to access. And then after the fresh frozen confirming it is a cancer, they can undergo in the same procedure robotic resection or minimal invasive resection. A little bit of update to surgery for stage 1. There was a lot of evidence recently being published over the last 3 years that when you have a small lung cancer being below 2 centimeters in diameter, that sublobar resections, so-called segmentectomies, are the valid operations that can be done safely and with the same survival rates like lobectomy, which has been done in the past. Of course, the standards and the technical standards of the segmentectomy are very important because it's not widely or broadly done in the correct way, and we need a lot of planning for this. This is a typical 3D simulation that we do before the surgery. We see the localization of the nodule within the segment, also the anatomical structures leading there to the arteries, bronchi, and venous structures. This is the setup then in the robotic OR. We have 3 XI robotic platforms here in the University Hospital. And in the meantime, I can say that 92% of all anatomical lung resections in our department are performed minimal invasively, including all stage of disease. This is a typical robotic segment 6 resection, where you can see here the division of the segment 6 artery, and very nicely where we see the borders of the segment by applying ICG and visualizing which and how much amount of tissue needs to be resected. We're also historically a department performing a lot of lung volume reduction surgery, and this is why we go even into the extremes in patients with emphysema, but seeing here even a benefit of patients at 12 months in an increase of FEV1 and also other parameters as have been seen in other groups with less oxygen use because the hyperinflated parts of the lung are resected. So what else is quite exciting and new in early stage non-small cell lung cancer? This is a subgroup analysis of the CLGB trial from Al-Turki, where they looked at the lymph node dissection, being either lymph node dissection or systematic sampling or simple sampling. And you can see here on these Kaplan-Meier curves of disease-free and overall survival stratified by mediastinal lymph node dissection or not, that there was no difference. But this was only a subgroup analysis. There is currently just published a paper from China where they did a randomized controlled trial, and it seems for purely GGO adenocarcinoma patients, there's also no benefit of performing extensive lymphadenectomy. Another very exciting trial coming up in the early stage setting, Dr. Hendrikks has been speaking about what's next for the high-risk featured early stage non-small cell lung cancer. And this is here an ADC trial, TROP12, which is going to start or has started in the US, will soon start in Europe, run by the Thoracic European Surgical Trial Platform from the European Society of Thoracic Surgery. So what's new for the locally advanced? This is a similarly busy table. I think all of us have these tables. I have to thank Raphael, Werner, Nina Steinmann, and many people helping to constantly extend this table with new data. And I think we have spoken about NeoAdora, so I will skip this. Maybe just one part I would like to mention, that not only MPR have been very sad. The results, in particular the PCR rates, were very sobering, with 4% and 9% in the combo or mono arm. And EFS, as has been stated by Dr. Hendrikks, is all now mature data at this stage. The question we're all asking all over and over again in our tumor boards is about the resectability status. Also, this has been nicely presented by Dr. Hendrikks. And it's important to say that for these borderline or potentially resectable situations, it is important to perform trials. And I would highly recommend to use this classification for the trials to have comparable results. I will also skip this. MDT bridge is for exactly these borderline cases and borderline resectable situations. And also this has been presented by Dr. Hendrikks. I just want to repeat one more time that the overall resection rate was very high with 85.7%. And the majority of the patients had R0 resections. This is a case here I would like to present to you also for these situations. It's a 50-year-old patient with a highly, normally to say, unresectable case of a pancreas tumor. And you see, I will repeat the video again, after chemo IO, which has been done in a different institution, there is quite a nice response. And we can even resect these extended tumors. And nowadays, minimal invasively, you can see here how I'm dissecting the bundle of the artery and the plexus below the first rib, which was previously secured by a supraclavicular incision with this structure that you can see here. And finally, you can save the plexus, the artery, and everything, and the patient had an R0 resection. A question that we get often and is, I think, interesting for you to learn here, are the surgeries more complex for us as surgeons after induction IO? And it can be as easy as you can see here. The lymph node nicely is dissected from the pulmonary artery. The tissue nearly is, I would say, virgin, and it's easy as if the patient had never induction. But it can be as complicated as this case here, where this wasn't even predicted. The CT scan on that is just showing here looks quite doesn't look very dangerous, but you can end up during surgery, surprisingly, in a situation which is highly complex. You can see here the bronchus is stuck to the pulmonary artery, which is right behind. You can see how I'm hesitating to go behind, not to make a hole into the surgery. And for these cases, you really have to be prepared with the whole team to convert or at least secure the main PA, even robotically, to control any particular bleeding. We need also advanced techniques like you can see here, where we perform so-called sleeve resections, suturing the bronchus after dissecting it openly. A last word about the most advanced stage of non-small cell lung cancer, stage 4, and here the role of surgery, which is obviously only in the oligometastatic state. Just briefly to say, across several guidelines, surgery and radiotherapy have a role in the oligometastatic disease setting based on numerous phase 2 and 3 trials here without targetable molecular alterations. One of the trials being the CHESS-ETOP trial. You will hear more about it later from Dr. Werner. So in summary, surgery is currently the recommended primary treatment for non-small cell lung cancer patients who present with early stage disease. And the diagnosis of lung cancer in very early stage will increase with implementation of lung cancer screening programs. The technical evolution will make diagnosis and surgical therapy more and more efficient and less invasive with precise planning. In stage 2 and 3 surgery is in conjunction with immunochemotherapy superior to neoadjuvant chemotherapy across surgical, pathological, and also efficacy outcomes. Patients with oligometastatic disease can benefit from the addition of local therapy to systemic therapy, and morbidity and mortality are rather low with the advances in surgery and radiotherapy. And with this, I would like to thank you for your attention, and maybe we have even time for one question before we move to the other local therapy. Thank you very much.
Thanks. I will give you a quick update in 10 minutes about some important developments in lung cancer. And I will focus on 3 different sites: early stage, locally advanced, and oligometastatic. Let's start with early stage. You've seen already that the landscape and the treatment for early stage has been changing based on the US trial and also based on the Japanese trial, which compared sublobar resection, segmentectomy, even wedge resection compared to lobectomy for patients having small tumors less than 2 centimeters. And it was quite interesting that the standard has changed because, I mean, if you look at the recurrence rates, it was higher in the sublobar resection, about twice as high. You can see it on the slide here. And still, the overall survival was being beneficial for the sublobar resection. It was a non-inferiority trial, so the non-inferiority was matched, but at least there was a numerical advantage. So it appears that you can call it less is more in this setting of surgery. And being a bit provocative to wake you up, why not become even a bit less, let's call it invasive for radiation? There's so what we've seen just at the last ASTRO meeting is the long-term outcome of the revised STARS trials. This was a prospective single-arm phase 2 trial where patients at the MD Anderson Cancer Center, so with very high surgical expertise, have been selecting patients who were operable, and then they were offered a non-invasive treatment, SBLT, and they reported a 10 years outcome in this trial. And if you look at the overall survival at 10 years, it's 69% for SBLT and 66% for surgery, which is effectively the same. So excellent long-term survival. And if you look at the disease or cancer-specific survival, it's 92% for radiation, and it's 89% for surgery. So this is, I think, excellent outcome data, as good as it can get at this stage, with no significant difference, non-inferiority being shown, and numerically even an advantage for the non-surgical approach. If you look at the recurrence pattern, it's very similar to the story you've seen for the sublobar resection. There is more recurrences after SBLT, and it's about the same. So you have more, in particular, local and regional recurrence, but patients are amenable to a salvage treatment, salvage resection, salvage radiation, or whatever. And in the end, patients keep more resources for follow-up treatments. That could be the rationale explaining that survival is equivalent, maybe even better, despite patients having fewer recurrence. So we are currently planning a prospective trial where we want to translate that mechanism of combining lesser surgery and radiation to tumors which are 2 to 4 centimeters. This is a trial currently under preparation. How about the induction of IO? We had quite some hopes on the iSaber, which is 2 cycles of immunotherapy followed by SBLT for early stages. There was a single-arm phase 2 trial, which was super positive. And then there was the randomized trials. 2 of them are being completely negative. Again, showing something might be super promising, looking fantastic in single-arm trials, but we need to perform randomized trials. Otherwise, we will be blinded by our enthusiasm. And this is just one explanation. Why or potentially are these differences being observed? It could be the inclusion criteria. So maybe in the randomized trial, the Keynote and the SWOG trial, it was only early stages, whereas in the iSaver, it was recurrences. Maybe it was too much of systemic therapy in this frail population, which wasn't tolerated, and maybe it was also the sequencing. Let's switch to the sequencing in locally advanced stages disease. We heard a comment that the standard is the Pacific, unfortunately, because this trial has not been positive together with some others. The concurrent setting of immunotherapy and radiation. This is the Pacific 2 trial where durvalumab was added to radiochemotherapy, and this has been the outcome which has been reported before: progression-free survival and overall survival. Effectively, no difference at all between these curves. They are perfectly overlapping, and we all assume, well, this is a negative trial. This immediate combination, concomitant combination of radiation, chemotherapy, and IO doesn't work. In terms of safety, there was no signal that there was substantially increased toxicity, but I was quite interested to see the full publication of the trial. And you can see the forest plots on the left and the right for progression-free survival and overall survival. There's one parameter where the trial was super positive. It's the European population. And there's one cohort where the trial was completely negative. It's a non-European population. If you look at the hazard ratio for the concomitant setting in the European population, it was 0.64 for progression-free survival. It was 0.69 in overall survival for the European population. So if the trial would have been conducted in Europe only, it would have been the same magnitude as Pacific. It would have been the same magnitude as all the induction trials. Why is that potentially the case? Well, the reason is that there was no mandatory for EGFR testing. This was not done in the majority of our patients. PD-L1 testing that was required, but EGFR was not done. And in particular in the Asian patient population, this was lacking. And we know that patients having an EGFR mutation, they might not take a benefit of the IO. That is one explanation. It could also be the expertise, which is quite demanding, having a 3-modality treatment, radiation, chemo, and EGFR, reminding us again that this is not simply putting pieces together, and we need to be cautious to have a super strict and rigid inclusion criteria, and also have sufficient expertise for these complex multimodality treatments. The last topic I want to approach is oligometastatic disease. This is a slide I like because it's becoming more busy and busy. This is 20 randomized trials which have been tested in all tumor sites, all randomized trials which I'm aware of, which tested always the same question. What is the value of adding local treatment, metastasis-directed therapy, to standard of care systemic therapy? 20 randomized trials, most of them phase 2, 7 in lung cancer, 6 in prostate cancer, some in GI, breast, and also disease agnostic. On average, 16 of 20 randomized trials are being positive, which is quite surprising, that considering the effectiveness of today's systemic therapy. And if you just look at lung cancer, 5 out of 6 trials are being positive. If we talk about what is the local treatment modality which is driving the evidence, it is mostly radiation. Surgery is, of course, also an option. But if we treat patients today, it is based on evidence, and this is based on radiation. In 19 out of 20 trials, either all patients or the large majority of patients have been treated in a combined modality setting using radiation and standard of care systemic therapy. So where have we seen the most exciting data? This was in so-called oligopersistent disease. In EGFR mutated non-small cell lung cancer patients having an activating driver mutation being treated with osimertinib, as it has been done in the North Star trial. This is an overview of 3 randomized trials in this setting, which only enrolled EGFR positive patients, 2 in China, 1 in the US. 2 being a randomized phase 3 trial using only first generation of an TKI, and the last trial, the North Star trial, using osimertinib. All trials have been super positive, in particular the first 2 ones with the phase 3 approach, but also the North Star trial reported a benefit with a hazard ratio of 0.6. Let's have a slightly detailed look at the North Star trial, which has been reported at the ESMO meeting. Patients with not only oligometastatic, but kind of polymetastatic non-small cell lung cancer being treated with osimertinib about 2 months, and then patients were randomized to continuation of osimertinib plus minus locally consolidated treatment. Majority of patients have been again treated with radiation. About 1/3 of the patients were treated with surgery. Primary endpoint progression-free survival. And this is the primary endpoint progression-free survival, which was again positive, confirming that not maybe that despite, but even in particular because we have effective systemic therapy, the value of local treatment becomes even more positive. And there was no added toxicity by adding locally consolidated therapy. So as a quick summary, early stages, we see excellent results with long-term follow-up using an SBRT approach for locally advanced. Maybe we need to reconsider the sequencing based on this quite interesting subgroup analysis of PACIFIC-2. And for oligometastatic disease, we're seeing more and more evidence proving us that there's an added value of also going multimodality in oligometastatic and maybe even polymetastatic cancer patients. Thanks a lot, and looking forward to some questions and also to some food and drinks afterwards. Thank you.
Thank you very much. Other questions? Yes, Lisa.
And Matthias, thank you for the excellent presentation. And for oligometastatic non-small cell, we now have at least 2 trials that didn't reach the primary endpoint. ETOP-CHEST Part 1 was negative for the primary endpoint, and the NRG-LU002 was also negative. Do you think that we need to approach the immunotherapy and targeted therapy patients differently, or do you have an explanation why these trials were negative?
With the energy trial, I think we have to be cautious. We have seen an update now at the ASTRO meeting where effectively one kind of corrected risks have been, I would call it, corrected. So it is a negative trial, but I would really love to wait for the full publication. Otherwise, there's lots of speculation why this trial has been negative. It could be indeed be true that it might be a difference between driver mutated and non-driver mutated patients. There are some concerns about excessive toxicity, which has been potentially observed, but let's wait until the full publication. There's, to my understanding, a bit too much speculation at this point of time.
Yeah, we will hear a little bit more at the end of this session as well about that. Thank you, Matthias. And we move on to the next talk, which will be news on the systemic therapy given by Dr. Ulrich Richter, who's attending of the Department of Medical Oncology and Hematology. Thank you, Ulrich.
Thank you very much. Yes, next 10 minutes will be about news on systemic treatment of lung cancer. The advantage of being second last is that we have covered a lot of it already. And I will concentrate on late stage highlights. And due to time limits, I will pick 3 topics: EGFR, HER2, and IO bispecifics. In this year, at least until now, the most important news for stage 4 systemic treatment is about EGFR mutant non-small cell lung cancer, and that is due to the results of Mariposa published at ELCC in March this year, and FLAURA2 at WCLC in September this year. Mariposa, for short, is a first-line treatment in EGFR mutant non-small cell lung cancers, comparing amivantamab, a bispecific MET antibody, and EGFR antibody combined with lazertinib, an EGFR TKI, compared to osimertinib mono, and that showed a significant overall survival benefit. FLAURA2, the other trial, combining osimertinib with chemotherapy compared to osimertinib mono, the standard of care, as well, significantly for overall survival benefit. So that leads to the conclusion that osimertinib mono is no longer standard of care, and the combination is standard of care. However, it causes some questions. What regimen is better? Are there subgroups of patients with a higher benefit from the one regimen or the other? Are there thoughts about probably sequences? What is the best first-line treatment concerning next lines of treatment? All these questions are not answered yet. Going on, what else do we have? TROP2-directed ADCs for EGFR mutant non-small cell lung cancers. There's a pooled analysis for datopotamab deruxtecan in patients in third line for EGFR, after EGFR TKI and chemotherapy, a pooled analysis from 2 trials, TROPION-Lung 05 and TROPION-Lung 01. They gathered 117 patients, median age 63, and most of them female, most of them Asian. The median number of prior lines of therapy is 3, and most of them received osimertinib. For these patients in the 4th line of treatment, overall response rate was 43%. Duration of response 7 months, progression-free survival 6 months, and overall survival 15 months. And that led to an FDA approval this year. There's another TROP2-directed ADC, zakituzumab tirumotecan. It's quite difficult, so I call it SAC-TMT. And there are 2 trials which are important. OptiTROP-Lung 3 and 4. One presented at ASCO, the other at ESMO. The first one is a third-line trial. So these patients were treated with EGFR TKI and chemotherapy, and in the third line they received either SAC-TMT or docetaxel. This trial was positive with a progression-free survival of 7 months, and over here, and 3 months in comparison, and overall response rate of 45%. The second trial moved a step forward to second line. So these patients were treated with EGFR TKI in first line, and then in second line with SAC-TMT, and as well this trial was positive. So this is a probable second line of treatment, but the question is who should get this kind of second line, knowing we have MARIPOSA-2, unsolved question at the moment. But there are further trials in progress, as stated here. What else for EGFR mutant non-small cell lung cancer? We've got the COMPEL trial. COMPEL trial is a second line trial, so these patients as well received first line osimertinib, and then one part of the population received chemotherapy combined with osimertinib, so they continued with osimertinib, and the second part, this group, only received chemotherapy, and this trial was positive as well, with positive progression-free survival in general, and they did CT scans every 6 weeks and brain scans every 6 weeks as well, so they could differ between the CNS progression-free survival and the extracranial progression-free survival, and everything was positive as well. So this could be a probable second line of treatment for patients who are not able to receive amivantamab in second line. However, we have to keep in mind only patients who had no progression in the CNS after osimertinib were included. So it's only for non-CNS progressive patients. Final slide for EGFR mutant non-small cell lung cancer. HER3 directed ADC, Hertina Lung, presented at ASCO 25. It's another ADC used in second or third line compared with chemotherapy. It's positive in progression-free survival, however, negative in overall survival. So that was the reason why the application for FDA approval was withdrawn. And then there was the Harmony trial presented at WCLC in September, and they used ivonescimab, a bispecific against PD-1 and a VEGF, and compared to chemotherapy. Again, this trial positive for progression-free survival, negative for OS. So we do not really know which kind of role these drugs play in the EGFR mutant non-small cell lung cancer. So short summary for the EGFR mutant non-small cell lung cancer. Combination is standard of care in first line. TROP2 ADC is probably a second line option. Continuing osimertinib together with chemotherapy is another second line option, and we do not know the role for HER3 ADC or ivonescimab in EGFR mutant non-small cell lung cancer. Second topic, HER2. There were two trials, SOHO-1 and BEAMIAN Lung, both presented at ESMO. For HER2 mutant non-small cell lung cancers. SOHO-1 used zivabertinib, an oral reversible TKI, which inhibits EGFR and HER2, and BEAMIAN Lung using zongertinib, again an oral but irreversible TKI, selectively inhibiting HER2 but not EGFR, and therefore probably sparing some of the side effects. Both are effective. There are several cohorts, pre-treated but not HER2 directed, treatment naive, or pre-treated with HER2 ADC. Overall response rate 71% or 38% in the pre-treated HER2 directed cohort. Side effects, mainly diarrhea, rash, and stomatitis paronychia. And for zongertinib as well, overall response rate in treatment-naive patients, 77%. Side effects similar, however, incidence seems to be lower than for zivabertinib. There are several ongoing trials for first line, so we are facing problems in first line for HER2 in the next years. And last topic, IO bispecifics, Harmony 6 presented at ESMO. Ivonescimab, we already heard about, bispecific antibody against PD-1 and VEGF, together with carboplatin and paclitaxel chemotherapy compared to tislelizumab, a PD-1 checkpoint inhibitor, together with carboplatin paclitaxel in squamous non-small cell lung cancer, no prior therapy. Positive trial for PFS. We do not know the OS data yet. We have got the adverse events, especially the ones for the VEGF part, proteinuria, hemorrhage, and hypertension, quite manageable. Probably an option for squamous non-small cell lung cancer. So, to summarize, we have a combination in first-line EGFR mutant non-small cell lung cancer. But what is the proper first line? We do not know. What are the groups of patients or subgroups receiving which kind of regimen? And the question remains, who should not receive the combination and osimertinib mono? So, are we allowed to compare the trials? I don't know. We need the subgroup analysis, and we have to think about treatment sequences. So, what is the proper second line? Mariposa after FLAURA2, chemotherapy re-challenge, exactly a re-challenge, or osimertinib plus chemotherapy, or the ADC. HER2, we are facing the same problems as above for the EGFR in the next 5 years probably, and IO bispecifics have the potential to change the landscape for non-mutant non-small cell lung cancer, and that's it.
Thank you very much. Are there questions from the audience, speakers, online? No. Okay, so thank you very much again. And then we move on to our last talk from Dr. Raphael Werner, who is a junior attending in our Department of Surgery, and he will present ongoing studies and some research of the oligometastatic disease setting. Thank you, Raphael.
Perfect. So also good evening from my side, dear ladies and gentlemen. It's an honor to conclude this symposium with a presentation of a few clinical studies that are ongoing in our Comprehensive Cancer Center. All these studies are focusing around the topic of oligometastatic disease. It's the ETOP-CHEST trial, it's the Salvage trial, and it's the flagship project of the Comprehensive Cancer Center, the OMD-ZH. These are my disclosures. We have already heard quite a bit about oligometastatic disease. The initial presentation or introduction of oligometastatic disease goes back to 1995 when Hellman and Weichselbaum introduced this concept of an intermediate stage between disseminated disease and very localized disease, suggesting that these patients may also be amenable for local treatment and may benefit from local treatment. And in the meantime, we do have randomized studies that have demonstrated the benefit of adding local treatment to the systemic treatment in oligometastatic non-small cell lung cancer. And the addition of local treatment has also found its way to the guidelines of both radio-oncologists and thoracic surgeons. However, oligometastatic disease remains a very heterogeneous entity with many different ways of clinical presentations. And from the clinical standpoint, it's very hard to differentiate whether patients that present with oligometastatic disease are really in a true oligo setting and will remain oligo also in the future, or whether the current oligo situation is just the tip of the iceberg and many more metastases or disseminated disease will follow in the future. In addition, the evidence for local ablative treatment is mostly originating from retrospective data from the era before immunotherapy, and patient selection remains a big challenge for this patient cohort. So I'm starting with the first trial that I will present, the ETOP-CHEST trial. This is a multi-center, single-arm phase 2 trial assessing the efficacy of immunotherapy, chemotherapy, and stereotactic radiotherapy to metastasis, followed by restaging, and then definitive surgery or radiotherapy to the primary tumor in patients who are non-progressing in a cohort of patients with synchronous oligometastatic non-small cell lung cancer. Patients are included if they have histologically confirmed synchronous oligometastatic disease. A maximum of 3 distant metastases is the inclusion criterion. At least 1 metastasis should be a brain metastasis, should be an extracranial metastasis. And it's allowed to resect 1 brain metastasis or 1 adrenal metastasis before randomization. Patients should have a good performance score. Tissue should be available for translational research projects. And of course, patients with driver mutations, EGFR, ALK, and ROS1 are excluded. The trial has 2 cohorts. Cohort 1 has recently been published. Cohort 2 is currently ongoing. Here we see the treatment scheme of cohort 1. Durvalumab is the immunotherapy agent that is being given. It's continued for an entire year after definitive local treatment to the primary tumor has been performed. And as I mentioned, the publication of the cohort 1 has been very recent. A total of 49 patients were included in this first cohort. Out of the 47 patients who were starting treatment, unfortunately 10 patients progressed very early and 2 patients even died before restaging, which leads to a PFS of just 33%, and therefore the null hypothesis could not be rejected or the pre-specified endpoint was not reached. However, the 1-year overall survival was nevertheless 74%, and treatment-related adverse events were very rare or very manageable. So this led to the conclusion, although that it did not meet the primary endpoint, the trial team decided to further intensify the systemic treatment by adding the CTLA-4 inhibitor tremelimumab in a subsequent cohort. This is cohort 2 that is currently recruiting. It's recruiting in 4 different countries, in Switzerland, in Spain, in Italy, and in the Netherlands. And you see tremelimumab is just given before the definitive local treatment to the primary tumor, whereas durvalumab is continued as it was in cohort 1 for an entire year after local treatment of the primary tumor. The second trial that I will be talking about is the Salvage trial. This is a phase 3 randomized controlled trial that compares maintenance with the addition of local ablative treatment in patients with stage 4 disease. The trial is sponsored by the Swiss Cancer Institute, and Professor Opitz is the trial chair. Patients are included if they have tissue-confirmed stage 4 disease. Patients are only randomized once they have completed an induction with 3 cycles or 3 months of standard of care systemic treatment and present with a partial remission or a stable disease, and therefore present kind of in an induced oligometastatic or oligopersistent setting, here defined as a maximum of 5 residual extracranial distant metastases. In addition, up to 5 cranial or brain metastases are allowed for inclusion, making it an inclusion for an entire of up to 10 metastases for these patients. The primary tumor and all oligometastatic lesions must be amenable for local ablative treatment, and of course disseminated metastases like leptomeningeal metastasis or malignant pleural effusion, malignant ascites cannot be included. This is the trial scheme. As I mentioned, the randomization only takes place after the induction treatment and restaging, and then a randomization to either local ablative treatment to the primary tumor and to all metastatic sites is being performed, or standard of care is continued with a systemic anti-cancer agent. What is special about this trial is its primary endpoint, or to be more precise, the 2 co-primary endpoints, one being PFS and the other one being quality of life by patient-reported outcomes measured by the EQ5D5L questionnaire at 6 months after randomization. We're aiming for a sample size of 128 patients, and there's several centers in Switzerland that are currently recruiting, and we're hoping to have some additional foreign centers that are joining the study team. And the last project that I will be presenting is not a clinical trial, it's a translational focused project. It's the C3Z oligometastatic disease program. It's a flagship project that aims to advance our clinical understanding and our biological understanding of oligometastatic disease, thereby improve patient selection and also personalization of treatment. It's very multidisciplinary and multi-professional, and it doesn't only focus on non-small cell lung cancer, but also focuses on prostate cancer, head and neck squamous cell carcinomas, and other oligometastatic entities. There are 4 different work packages. Work package 1 is coordinated by the radio-oncologists, by Matthias Guckenberger, which focuses on imaging biomarkers and the integration of radiomics and deep learning approaches on these oligo patients and subsequent images that are being performed. Work package 2 is coordinated by the Department of Thoracic Surgery and focuses on tissue-based biomarkers, where we do spatial transcriptomics, where we do next-generation sequencing to metastasis. Work package 3 is coordinated by the Department of Immunology of the University of Zurich. It focuses on blood-based biomarkers and aims to identify peripheral immune signatures that are characteristic for oligo disease. And work package 4 aims to generate a personalized decision support tool that also takes into account the personal quality of life preferences and the quality of life decisions of each patient. As I mentioned, our department is mainly focusing on work package 2. We're currently identifying patients that qualify for the analysis. We are gathering tissue for a tissue microarray, performing a next generation sequencing, and we'll be doing a spatial transcriptomic analysis on the tissue microarray. Of course, these 3 studies that are performed at the University Hospital in Zurich are just the tip of the iceberg of all clinical trials that are recruiting within the Comprehensive Cancer Center Zurich. At the moment, it's 85 recruiting clinical trials. You can access these trials via krebsstudien-zürich.ch and find all the details here. So with this, I would like to thank you for your attention. I'm looking forward to discussion.
Thank you very much, Raphael. Are there any questions to ongoing research? I think it also answers a little bit your question. We need more information of what is really behind this oligometastatic disease to select the right patient for these therapy approaches. Questions online? No. Okay, thank you, Raphael. And I would like to thank one more time to the amazing faculty, to all their insightful talks, for all the participants here in the audience and online, for your interest on this update on non-small cell lung cancer. And I would like to invite you now for an aperitif outside. And don't miss also to thank Silke Uflacker, who has amazingly arranged and organized everything. Thank you, Silke.